The shot is a wire, a thin one. It feeds through the working channel of a duodenoscope, down past the back of the throat, past the stomach, and stops at the back of the duodenum. There is an opening there the size of a grain of rice. The job is to thread the wire into the bile duct on the first try. The pancreatic duct sits next to it, 2 millimeters away. The patient walked in this morning with right upper quadrant pain. If the wire enters the wrong duct, the procedure causes pancreatitis. She leaves the hospital days later in a worse place than she came in. 40 of these, a week, every week, for the next 30 years. Level 1, medical student. Tuition is $60,000 a year. Living expenses are another $30,000. By the end of MS4, your principal alone is $223,000. The AAMC mean for the class of 2025. The interest meter started running the day you matriculated. It does not pause for clinical rotations. MS3 is the year of clerkships. 4 weeks of internal medicine, 3 weeks of surgery, 2 weeks of pediatrics, then OB, then psychiatry, then neurology, then back-to-back electives. Each block joins you to a team of 2 interns and a senior resident. The day starts with pre-rounds at 6, rounds at 8, afternoon admissions, sign out by 5 if it's clean. You carry a folded patient census in your white coat pocket. You add a line to it every time you hear a new term. MS3 Spring. UWorld is open on your laptop at the library carrel you have claimed for 9 months. 2,000 questions deep into Step 2. CK Prep. The exam itself runs 9 hours, one Saturday in June. You take it the week after your surgery shelf rotation. Score release is 6 weeks later. Your number determines which internal medicine programs read your application. The first endoscopy you ever watch is in the MICU on your medicine rotation. A cirrhotic patient is hemorrhaging from esophageal varices, third spacing fluid, on a norepinephrine drip. The GI fellow on call shows up in scrubs over a t-shirt and a pair of running shoes. She intubates the scope, finds the bleeding vessel in 90 seconds and bands it. The patient stabilizes. You hold the suction tubing for an hour without speaking. That night you open your laptop and look up the GI fellowship pipeline for the first time. Internal medicine residency, 3 years. GI fellowship, 3 years. Advanced endoscopy, 1 more year, 11 years after starting medical school before you scope on your own. 3 weeks later, overnight call. The radiologist has not dictated yet. You pull up the CT on your phone in the call room and see a small crescent of free air under the right hemodiaphragm. You page your senior. He looks at the screen for 10 seconds and signs off without changing a word. 2 days later, he starts asking what you think before he tells you the plan. You don't know yet that the GI fellow with the running shoes is going to interview you for fellowship in 5 years. Match day. You rank internal medicine. Level 2, internal medicine intern, PGY1. Salary is $68,166. The AAMC mean for July of 2025. Hours are 80 per week on paper, more on the bad weeks. Your loan principal is now $228,000 and climbing. The intern year has a rhythm. Pre-rounds at 5:30 a.m. on 6 patients, notes by 7, rounds at 8, with the attending who wants the pertinent positives and only those. Sign out at 6 p.m. if the day was clean, 8 if it wasn't. Drive home with the radio off. Cases stack up that have nothing to do with GI. A diabetic ketoacidosis at the start of your ICU month. Insulin drip, fluid resuscitation, slow correction over 6 hours. A heart failure exacerbation on the regular medicine service. Diuresis, weights, oxygen titration. A community-acquired pneumonia that turns out to be pulmonary embolism on the 2nd day of admission. You learn that the diagnosis you do not consider is the one that hurts the patient. By April, you stop calling the senior for help on routine admissions. 3 a.m. October, the ICU pages you about a cirrhotic in bed 7, pressure tanking on a norepinephrine drip, coffee grounds suction in the NG tube. You walk in. The GI fellow is already there in scrubs over a t-shirt, the same fellow you watched in MS3. She lets you hold the bite block while she scopes him. 2 bands placed, 1 transfusion running. He stabilizes by sunrise. She walks out at 6:15. You stay for rounds. Step 3 is the next exam. 2 days computer-based case simulations scheduled around your night float block. You sit for it in March on a vacation week and pass without ceremony. The certificate arrives in a cardboard tube. You put it in a desk drawer. Every test from here is run by your specialty board, ABIM. PGY2 is when GI applications open. Your senior fellows tell you the unwritten parts, which research labs publish, which program directors call on your behalf, which letters carry weight in the application pile. You sign on to a case report with the GI division and start writing on Saturdays. You take elective time on the GI consult service in November, 4 weeks rounding alongside the senior fellows. They let you write the recommendation each morning. Before the attending sees it, they edit it. You learn the difference between an effective consult note and a wasted one. The wasted one restates the primary team's question. The effective one answers it in 2 lines and lists what to do next. The first solo admission you run without paging anyone is a 48-year-old man with idiopathic acute pancreatitis. You take the history, get the labs, set up the IV fluids, and make the call about NPO versus enteral feeds. Your senior co-signs the plan in the morning without changing a single line. You eat your first hospital meal sitting down in 3 weeks. 2 more years on the floors. Level 3, GI Fellow, PGY 4 through 6. Salary is $77,000 the first year, climbing to $85,000 by PGY 6. 3 years of fellowship, 7 years post-MD, still earning a residence stipend. Your loan principal is $240,000. Friends from college who took banking jobs are buying houses. The first board exam comes early, ABIM internal medicine, taken in late August, right after residency ended. Results in October. You pass on the first attempt. The cardboard tube goes in the same desk drawer as step 3. The first solo colonoscopy is on a Monday in your first PGY 4 block. Cecum in 9 minutes. A small tubular adenoma in the ascending colon, snared cleanly and clipped. Your attending sits in the corner with coffee, watching but silent. You walk out with the report. The patient's outcome was entirely yours. The day in fellowship has a shape. Morning conference at 7. Endoscopy block at 8. 6 to 10 cases by noon. Afternoon clinic if it's a clinic day, hepatology consults if it's a consult day. Notes from 7 p.m. until they're done. By PGY 5, you are running an ERCP list with your attending across the room. You guide the wire. They call the shot. Some fellows lean advanced and some do not. Your hands are steady at the duodenoscope's elevator, the mechanical lever that aims the wire toward the papilla. Your attending notices. PGY 5. Spring, you walk into a clinic exam room and tell a 65-year-old man that the biopsies from his screening colonoscopy came back as adenocarcinoma. His wife is in the chair next to him. You explain what comes next. Staging CT, surgical consult, oncology referral. He asks if he is going to die. You say what your attending taught you to say. You drive home with the radio off. The next morning's first case is another screening colonoscopy. ABIM gastroenterology is the bigger board. 10 hours, 1 day. You spend Saturdays at the hospital cafeteria with the GI Board review series for 6 months. Results land in February of your advanced year. That certificate lets you bill as a gastroenterologist for the rest of your career. PGY 6. The program director pulls you aside after a Friday morning teaching conference. He says one sentence. You should think about advanced endoscopy. You spend the weekend in your apartment looking at the ASGE Match website. 79 programs, 96 positions, no board certificate at the end, 12 months of training, a letter from a program director, and your hands. The first time a wire goes selectively into the bile duct on attempt 1 is in month 8 of fellowship. The fluoroscopy image shows the duct lighting up against the black. Your attending nods. You don't smile, but your hands stop shaking. 3 years in. The choice. Level 4. Advanced Endoscopy Fellow, PGY 7. The ASGE Match Day was last November. You're one of 96 advanced endoscopy fellows in the country. Salary is $80,000 for the year. 8 years post-MD. The fellowship itself runs 12 months, not ACGME accredited, not a board certificate, just 12 months of running the hardest procedures in the field. The week has a fixed shape. Mondays you do ERCP, Tuesdays endoscopic ultrasound, Wednesdays mixed, Thursdays POEM, and complex polypectomy. Fridays the case log updates at noon, and you read the line at the top, cannulation success this week. The number matters because it tracks whether you'll be competent in July. The hours are not the worst part of the year. They run 65 to 70 a week, less than residency. The worst part is the cognitive load. Every Friday afternoon, you replay the week's cases in your head and grade your own technique. Early months, you forget which catheter pairs with which scope. You call a stricture tight instead of high grade, and the attending corrects you on the dictation. The tech across the table hands you the wrong size sphincterotomy twice before you stop asking. The room does not slow down for you to catch up. The first morning you pick the guide wire off the tray, you do not yet have a name for the brand. By month 11, you can identify it by the resistance it gives back. The first time you cause post-ERCP pancreatitis is in month 3. A 41-year-old mother of 2, in for a stone clearance, comes back to the emergency department that night with abdominal pain radiating to the back. Lipase comes back at 2,000. She admits to the floor. She does fine on a fluid resuscitation. She goes home in 3 days. You do not sleep that week. You hit a patient with a disease she did not have when she walked in. The procedure was elective. You chose to do it. There is no surgical subspecialty in medicine that does this in quite the same way. ERCP causes pancreatitis in a measurable percent of elective cases, every year, in every center. You remember her file for longer than you expected. 2 months later, another case has a close call. 2 months after that, another. You don't know yet that she'll file suit a year and a half from now, not for the pancreatitis, for the consent conversation. The carrier will handle it. You will settle on paper. By month 9, per oral endoscopic myotomy, POEM, the third space procedure your attending lets you run start to finish. The patient is a 60-year-old with achalasia who has not swallowed water without pain in 6 years. You tunnel through the esophageal mucosa, find the muscle layer, and divide it with the electrocautery knife. The patient comes back to clinic on post-op day 1 and drinks a cup of water in front of you. She cries. You leave the suite and do not talk to anyone for 10 minutes. By month 11, your cannulation success rate hits the threshold the society sets for competence. You stand in the suite on a Tuesday morning, take a fresh wire off the tray, and select into the bile duct on attempt 1. The attending logs it. Nothing else changes. The exit interview with the program director is in May. He hands you a single sheet of paper, the institutional certificate. He says, you can practice now. 12 months, then it's yours. Level 5, first year advanced endoscopy, attending. Starting salary is $450,000 at an academic program, $500,000 to $600,000 in a hospital-employed community position. Private gastroenterology, partner track, sits higher and comes later. You took the academic offer at the place where you trained. You are 8 years post-MD plus the advanced year, 30 years old by November. Mondays are your procedure day. 6 a.m. you're in your office reviewing the day's case images, CT scans, MRCPs, prior ERCP reports if the patient has had one. 7:30, you're in the suite, apron on, leaded glasses over your prescription frames. First case is a common bile duct stone in a 64-year-old. Cannulation, sphincterotomy, balloon sweep, plastic stent for drainage. 42 minutes total. The patient is in recovery before 8:30. 6 cases by 3 p.m., clinic until 6. The first solo ERCP without a backup attending in the suite is a Wednesday in your 3rd month. The wire goes selectively on attempt 2. You exhale through your mask, and the gown tech across the table does not notice. The patient does fine. You drive home and sit in the car in the garage for 10 minutes before you go inside. Month 4, 2 a.m. call from an outside hospital. A septic cholangitis patient is on 3 pressors, and the local team cannot get a wire into the bile duct. You drive in. The case takes 30 minutes. The wire goes selectively on attempt 2, and the metal stent deploys clean. The patient survives. You leave the suite at 5:15 a.m., sleep for an hour in the call room, and round at 7. The first quarterly dosimeter reading comes back from radiation safety the next week, 210 millirem over 3 months. Your senior partner, 18 years in, pulls his badge off his apron and shows you his cumulative reading, 15,000. He flips the badge over so you see the issue date stamped on the back. He says, "I started this job with one of these in 2007. By month 7, the patient from your fellowship year, the mother of 2 with the post-ERCP pancreatitis, files suit. Not for the pancreatitis itself, for the way the consent conversation went. Your malpractice carrier handles it. You will settle on paper within a year. The senior partner tells you every advanced endoscopist he trained has been named at least once. You believe him. The apron weighs 14 pounds. You wear it 6 hours a day. Your lower back starts hurting in a specific spot at the end of each block day. The pain does not go away on the weekend. By month 10, complex Hiller strictures that scared you in fellowship are routine. The wire goes selectively on attempt 1 most days. You stop replaying the cases at night. Your first consult intern rotates with you in November, a first-year IM resident interested in GI. She asks if she can hold the scope on a stable screening colonoscopy. You let her drive 5 centimeters of insertion. The senior partner across the room watches without saying anything. She walks out at the end of the day with the clean report in her hand. 5 years, then 10. Level 6, Senior Attending and Endoscopy Unit Director. Compensation at this level depends on the structure. Academic Senior Attending, 600,000, Hospital Employed Division Chief, 700 to 800, Private Group Partner with Ambulatory Surgery, Center Equity, north of 900 and into 7 figures for the highest volume operators. You are at the academic place where you trained. You took the directorship 6 years ago. The job is no longer just procedures. You sit on the credentialing committee. You write the unit's quality reports. Your inbox runs 300 emails a week from referring physicians, fellows, industry reps, and billing. You still scope 4 days a week. You will not give that up. Thursday morning, the GI division holds Advanced Cases Conference. The fellows present. You sit in the second row with coffee. The advanced fellow this year projects an MRCP of a Roux-en-Y patient with a stricture in the afferent limb and walks the room through how she'd approach it. A junior attending in the back asks a sharper question than the chief resident does. You write it down. The hard cases come to you because everyone else tried. A Whipple patient with altered anatomy and recurrent cholangitis is on the schedule Tuesday morning. The afferent limb sits at the wrong angle. You set up the duodenoscope, advance the wire on attempt 4, and deploy the metal stent. 40 minutes. You hand the scope to your advanced fellow at the end and let her drive the next case. She gets selective cannulation on attempt 1. You nod once. Same nod you got 15 years ago. Maintenance of certification cycles every 10 years. You resat for the GI boards at year 10 without studying as hard, passed, then resat at year 20. Every 2 years, you log CME hours. Every 2 years, the hospital recredentials your privileges. ERCP, EUS, POM, EMR, ESD, listed line by line on a privilege form the credentialing nurse hands you on a clipboard. Your cumulative dosimeter reading is 11,400 millirem. The orthopedist you see for your cervical spine says the disc at C5 and C6 is degenerating and won't get better. 2 of your fellowship classmates left advanced endoscopy after 60. Back, neck, hands. You think about the next 10 years the way you used to think about the next 10 cases. A fellow you trained 3 years ago calls one afternoon. She just got selective cannulation on a case that beat 2 prior attendings at her institution. She wanted you to know. You take the call standing in the suite, scrubs still on, dosimeter still clipped to your apron pocket. 6:40 p.m. The last case of the day rolled out an hour ago. The room is empty except for the apron on its rack. You hang the apron on its rack at 6:45. The dosimeter stays clipped to the chest pocket. Tomorrow's schedule is already printed and sitting on your desk. 6 cases, first one at 7:30. The room is dark except for the recovery bay lights down the hall. The duodenoscope sits in the reprocessor. The wire trays will be restocked by the tech who comes in at 5. You walk past the recovery bay on the way out. 2 of the morning's patients are still being monitored. Both stable, both due home tonight. The night charge nurse waves at you from the desk. You wave back and push the door open. 15 years in, the setup at the table has not changed. Same scope, same wire, same 2 millimeters of bile duct. The pancreatic duct still sits next to it. Tomorrow's first case is a cholangitis. Wire in, sphincterotomy, stent. Patient in recovery by 8:30. The apron hangs heavy on the rack. The dosimeter still reads. In the morning, you put it back on.